I'd like to welcome you to this edition of the award-winning PRS Journal Club podcast with your hosts, Drs. Francesco Egro, Nicole Phillips, and Ira Savetsky. Enjoy.
Hi, everyone, and welcome to the December 2018 edition of the PRS Journal Club podcast. I'm Ira Savetsky, PRS Resident Ambassador from NYU, and as always, I'm joined by my co-resident ambassadors, Francesco Egro from the University of Pittsburgh Medical Center and Nicole Phillips from the Harvard Plastic Surgery Program. This is our last podcast, so before we get started, I just want to thank my co-ambassadors, Nicole and Francesco, for being so wonderful to work with this past year and who I've learned so much from, and I look forward to our future endeavors. I also want to thank Dr. Rourke for the opportunity to be an ambassador this year, and thank Aaron Weinstein, who is the senior managing editor of the journal, and all the support staff at the journal for all that they do. And lastly, I want to thank the listeners as well as our monthly guest moderators, as it is you who have made these monthly podcasts such a great success. Thank you. Today, we have the great honor of being joined by Dr. Justine C, the Bernard Sarnat Endowed Chair for Craniofacial Biology and Associate Professor at the UCLA Division of Plastic and Reconstructive Surgery. Thank you so much, Dr. Lee, for joining us for this PRS Journal Club podcast.
Thanks so much for having me.
A quick reminder, all of the articles that we will discuss can be read for free on prsjournal.com, including an archive of all past Journal Club articles. The article we'll be discussing is Evolving Trends in Textured Implant Usage for Cosmetic Augmentation in the United States by senior authors Dr. Mark Clemens, Keith Brandt, Jeffrey Kenkel, and Paul Soderna. I chose this article because breast implant-associated anaplastic large cell lymphoma continues to be a very hot topic in both the scientific literature as well as the mainstream media. Patients are becoming more and more aware of this rare disease, and it's important for us as providers to be able to counsel them effectively. Recent research has suggested a reproducible association between textured implants and the development of breast implant-associated ALCL. While rare, the presence of a textured implant is thought to drastically increase your risk of developing ALCL. An estimated 7% of breast plastic surgeons have reported personally treating a patient with a history of breast implant-associated ALCL, and 508 unique cases have been reported in 23 countries. Concerns for causing a malignancy in elective surgical patients have led the plastic surgery community to prioritize breast implant-associated ALCL investigation, with numerous recent publications on the topic and the creation of a national registry. Since the first reported case in 1997, the number of patients with breast implant-associated ALCL has been increasing rapidly, possibly as a result of more widespread adoption of textured implants or increased awareness and diagnosis. The purpose of this study was to identify the temporal trends of textured implant use since 2011, when the U.S. FDA identified association between textured breast implants and breast implant-associated ALCL. In terms of methods, maintenance of certification tracer data was queried between 2011 and 2015 for cosmetic breast augmentation cases submitted by American Board of Plastic Surgery diplomats. A nested random effects logistic regression analysis was used to identify associations between variables. In terms of results, 11,716 breast augmentations were performed by 880 unique surgeons. The overall proportion of cases using textured implants steadily increased from 2.3% in 2011 to 13% in 2015. The proportion of surgeons whose cases included both textured and smooth implants, as did those using textured implants, 0.4 to 4.4%. Significance remained after controlling for form-stable implants, suggesting an alternative motivation for use of textured implants. Subglandular cases, 20.5%, were more likely to use a textured implant than submuscular, 8.4%, or dual plane, 7.8%. Overall, I thought this was a really interesting study. The authors reported a significant increase in textured implant usage by plastic surgeons for cosmetic augmentations during this time period, 2011 to 2015. Not only did they observe an increased usage of textured implants by select surgeons, but throughout the study period, more plastic surgeons trended from exclusively smooth implant use to a practice intermixing both implant shells. Now, also important to note that some of these years correspond to the period when Sientra received FDA approval for their shaped textured implants, which was in 2012, followed by Allergan and Mentor receiving their initial approvals in 2013. Nonetheless, when after controlling for the use of form-stable implants, the increase in textured implants over time remained significant during the study period. Form-stable implants only represented about 5% of all augmentations in 2015, meaning that 204 of the textured implant cases in 2015 were textured round implants, 4 times the number of textured cases done only 4 years prior to 2011. It appears that surgeons are generally unconcerned about the potential association between implant texturing and ALCL given the rarity of the disease. The motivating factors driving the significant increase in textured implants over the past several years remain unknown. Now, there are some limitations to the study. The population, for one, is board-eligible American Board of Plastic Surgery diplomats, but it cannot be necessarily assumed that this is generalizable to all practicing plastic surgeons. Dr. Lee, I'm curious to hear some of your thoughts about this paper and perhaps what your experience was with textured implants either during your training or currently in your practice.
I thought this paper was very, very interesting and highlighted something that we really didn't know and is kind of perplexing, why one would see a rise in textured round implants being used. And I would agree with most surgeons, most plastic surgeons, in saying that BIA-ALCL is not a very common situation. It doesn't mean that one should just discard it and not think about it and not worry about it, but it's not a very common situation. So I think that if the indication were to exist and the patient is aware of the risks and for whatever reason this is the best option for the patient, then it's a reasonable thing to move forward on. What I don't know is what is that reason? What is it about that textured implant that's round that breast reconstruction or breast augmentation surgeons are so interested in? I'll say that from my standpoint, I don't do this operation, so I can't tell you why I would like one over the other. But I've done plenty of these operations in residency, and the only time we ever used textured implants was for expanders. And I can't think of a single time in which we have ever put in a textured round implant. And at the time, the form-stable ones that are shaped were not available.
Those are some great points. And similarly, during my training, I've never, in any case that I've been involved in, never used a textured round implant. And to be honest, textured implants overall is relatively a rarity that I've been involved in. Francesco, what are some of your thoughts about this paper?
I really enjoyed this paper, and I am truly surprised of the increase in using textured implants. I would have thought that the trends were actually going the other way. Here in Pittsburgh, most of our attendings have pretty much abandoned textured implants, and for this reason I'm really curious to hear what is the practice among the UCLA surgeons. I don't know if Dr. Lee you know, but also I would like to ask my co-ambassadors at Harvard, do they use textured implants or have they also kind of deviated away?
Certainly I saw textured anatomic implants being used primarily for breast reconstruction. For aesthetic cases at Harvard, primarily I saw smooth rounds. I agree with Dr. Lee's comment that the benefit of the textured rounds are not entirely clear to me, and I really did not see those in use at all in residency. And then I can also speak to, in fellowship, where I'm doing a significant number of breast augmentations. We use a lot of textured implants here, but they're, again, textured, form-stable anatomic implants, not textured. Actually, I take that back. We do use some textured rounds here as well. So I certainly have seen more use of textured implants here in Australia than I did in Boston. And in Boston, they were primarily for reconstructive purposes rather than cosmetic.
That's interesting. I'm from Italy, and the situation is fairly similar to what you're describing there in Australia, actually. Dr. Lee, are the other UCLA surgeons, are you aware if they're still using textured implants?
No, not that I'm aware of.
So what were your thoughts of the paper, Nikki?
As my experiences might suggest, I've really been thinking about this question a lot, and we've actually, we had a previous podcast talking a little bit about some of these questions. And here in Australia, I just went to a symposium in Sydney where I would say a vast majority of the plastic surgeons there are using textured implants. And so it's really been interesting to think about it from sort of two different perspectives. And, I know there's been a number of studies from groups here looking into risk factors for ALCL, and they've looked at really detailed information like different types of surface texturing, the role of bacterial contamination, which types of bacteria may be implicated in the development of the disease. And so this was a question I had sort of looking at this article was the conversation about ALCL and textured implants. Dr. Lee, do you think in this article it's perhaps too broad of an approach, or do you think that this broad and generalized approach is actually the appropriate one? So in other words, should we be looking for ways that we can take advantage of textured implants safely, or is the association with ALCL just too much of a risk factor and we should put them aside for now until we understand the disease better?
I think the main point of this paper is basically to highlight the fact that these textured round implants are increasing in usage. And that's with respect to the fact that there is such a thing as BIA-ALCL. I think that the question of what should we do since we are aware of such a thing as ALCL being present, I think what we should probably do is consider it with a bit of a grain of salt. The reason is because implants have been around for a long time. Textured implants have been around for a long time too. ALCL is just starting to become present in our literature and in the media because of some recent data. So we don't actually know, is this the beginning or is this the final data on that? So with that in mind, if there's a really excellent indication, if the patient is on board with that indication and willing to accept that risk, and the surgeon is willing to accept that risk, it is a reasonable thing to do. But if there's any reason why you could potentially use something else and the patient's worried about ALCL, then why wouldn't you use something else just to make that risk like none?
It's a great point to make sure, of course, that we're including our patients in the conversation and make sure that they're aware of risk factors and, decisions that are being made. I think that's a really important point, so thank you.
Nikki and Ira, I think we should also flag up to our listeners that we had Dr. Clemens giving live PRS grand rounds at ASPS. It was a really great lecture on ALCLs, and they can go on YouTube and on the PRS Journal website to listen again, to watch it again, actually.
Yeah, thank you, Francesco. I think those are some really great points. The one thing I want to add is that I have never had to have a discussion, with the patient about putting in these implants, because any patient from the resin clinic was never something that I thought I needed to use. But I can only imagine a breast cancer patient who just had treatment to eradicate it, and then you're having a discussion about potentially putting in an implant that could cause an additional malignancy, no matter how rare it is. I'm sure that's a challenging conversation. So once again, thank you everyone for a great discussion. If you like this podcast, please feel free to share with your colleagues and friends and rate us in the Apple iTunes store. Also, remember to tune in to the other 2 articles we'll be discussing on this month's podcast. And finally, please join us this month for our monthly journal club on Facebook, where we'll be able to interact directly in real time with this month's selected articles' authors. Go ahead and like the Plastic and Reconstructive Facebook page if you have not yet done so already, and it is there where our monthly journal club takes place. And thank you again, everyone, for a wonderful year, and I wish our incoming resident ambassadors, Raj, Lily, and Kyle, the best of luck, and I have no doubt that they'll do an outstanding job. And once again, thank you so much, Dr. Lee, for joining us.
Thanks for having me.